thank you for your attendance today. Before my original title, I'd like to introduce the controversy of ankyloglossia in Japan in 5 minutes. When I graduated from medical school in 1968, frenotomy was a common practice for surgeons, pediatricians, and midwives. But there occurred an anti-frenotomy movement in around 1980s. For instance, in 1985, the Japanese Society for Child Nutritional Research released a statement on the promotion of proper breastfeeding, which is good. But they also added in the statement, they said frenotomy should not be performed. And in 2001, the Japan Pediatric Society issued a position statement based on a survey of only 161 pediatricians and ENT doctors. The statement concluded that ankyloglossia does not cause feeding difficulties and therefore it should not be divided. Ever since, frenotomy was abandoned in Japan. In 2009, I retired from academic position of pediatric surgery of Kyoto University and started working with the pediatricians at the Children's Service of International University of Health and Welfare Atami Hospital. Atami is a famed sightseeing spot. It is well known for hot springs. And this small local hospital is one of the branch university hospital. And there, my frenotomy for babies with feeding troubles caused a furor among pediatricians. I have to convince them that frenotomy is effective in babies for breastfeeding. So I did the systematic review of literature using grade rating system. Grade is an abbreviation of grading of recommendations, assessment, development, and evaluation. The clinical question was formulated according to PICO. PICO stands for P for patient, I for intervention, C for comparison, and O for outcome. So I made the following clinical question. In infant with poor breastfeeding, does frenotomy improve feeding compared to lactation support alone? And this is the flow diagram of selecting publications. I put the keyword ankyloglossia and tongue-tie in English and Japanese literatures using PubMed, CINAHL, and Cochrane Library, and collected 505 literatures. And I narrowed down the literatures with keywords. Another keyword is frenotomy, frenoplasty, and breastfeeding. And from there, I excluded case reports, less than 10 cases, review, expert opinion, Q&A, letter to the editors. On the other hand, I added by hand research 2 observation studies, 1 guidelines, 1 guidance. And at the end, 4 RCT studies and 12 observation studies, 1 guideline, 1 guidance, 1 position statement met the criteria for study. And I reviewed the publications critically and rated the outcomes of the following outcomes. Latch and nipple pain as most important outcomes, milk production, continuation breastfeeding, weight gain, adverse events, diet distress as important outcomes. I will not refer to the details of analysis because it is in the paper published already, but there was no adverse effects and all outcomes prove that the craniotomy is effective for babies with feeding problems. So the answer to my critical question was, craniotomy does improve breastfeeding difficulties in infants with ankylosing. So I propose to formulate clinical guidelines to Japanese Society of Pediatric Surgeons and Japanese Society of Child Health. But their responses were as follows. Japanese Society of Pediatric Surgeons, they are busy, they are tied up with other guidelines. And Japanese Society of Child Health, it's not our business. But they discussed about this issue at the joint meeting, the joint committee of 4 pediatric societies, including Japan Pediatric Society and Japanese Society of Pediatric Otolaryngology. But the final response conclusion was, it is not necessary. Guideline is not necessary. Nobody is worried about it. Now, I'd like to go back to my original presentation. That's my present situation in Japan. The usefulness of a simplified tongue-tie score in decision-making for surgery. And there are several assessment tools to diagnose ankylosing, and the Hazel-Baker's assessment tool for lingual frenulum function is most maybe the famous one. It consists of appearance, 5 items of appearance and 7 items of function. And diagnosis of ankylosing is made by assessment score is equal or less than 8 points, and or function score is 11 or less. Surgery is indicated when lactation support fails. That's what Hazel-Baker said. But I think there is a limitation of this scoring, because this is applicable only in the young infants. And Martinelli, I hope the pronunciation is right, made a lingual frenulum protocol for infants of all ages. It consists of history and clinical examination. She said the interference of the frenulum may be considered when the sum of history score and clinical examination score is equal or more than 13. And Marchison, maybe one famous member of this meeting, developed the lingual frenulum protocol. It consists of general test and functional test. She says the frenulum may be considered altered when score of the general test is equal or greater than 3. And score of the functional test is equal or greater than 25. But in Japan, lactation consultant, midwives, speech therapists do not diagnose tongue-tie. If they have a suspicion of tongue-tie, they refer patients to doctors. If they go to pediatricians, they say, oh, there's no problem. The baby is growing and gaining weight with bottled milk. Okay? And if a patient comes into my clinic, I have to diagnose and decide the surgical indication at their first visit in a few minutes. This is how I see the patient. Maybe, sorry. Maybe many of you may take this kind of position to examine the baby. And so that I have simplified the tongue-tie score. It's a modification of Hazel-Baker's assessment tool. And I took item from item 1 to 4. I took the Hazel-Baker's assessment, and as item 5, I added the symptom feeling for infants, because the absence or presence of symptoms is important to decide the indication of surgery. And the operative indication is equal to 7 or less. The severity can be judged approximately by the total score: severe 0 to 3, moderate 4 and 5, and mild 6 and 7. And for the older children, I a little modified the items, assessment items. I replaced feeding with speech and swallowing in older child. And objective indication is the same as for infant. It is indicated, operation is indicated equal to 7 or less. Now, I think there are 4 important landmarks for the classification: tongue tip, and middle, transverse middle line, and haluncle, which is the opening of the ductal submandibular gland, and alveolar ridge. Based on these 4 landmarks, I made these classifications: tongue tip type, anterior type, tenting type or intermediate type, and posterior type. This is almost the same as Cottrell's classification, plus 4, 3, 2, 1, or type 1, 2, 3, 4. And tenting, I'll show you the photograph of the tenting type. I think you usually see it. Type, tongue tip type and anterior type and posterior type are the same as the Cottrell's. But tenting type, which I name, is the main part of the thigh end at the caruncle, but by lifting up or traction of the thigh, the mucous membrane between caruncle and the alveolar ridge just spread out in a tent fashion. I call it tenting type. And the operative procedures, I use the scissors, not laser. I release the thigh by scissors under topical application of 2% viscous lidocaine. I need 2 assistants, one hold the head and the other hold the body. The baby is swaddled by the towel. And the photo on the right shows the incision after the wound. After the incision is in a diamond shape. I try to cut into the base of the tongue, but not to cut the vessels. The vessels are running there. I need to be very careful. And operative indication of lip type are same for growth class 3 and 4. And the operative procedure I do is also released by scissors, and the local injection of 1% the lidocaine with epinephrine. And after the incision, I teach mothers how to stretch. I use the YouTube titled Stretching Exercises Following Tongue Tie and Lip Tie Release by lieratures and Pediatric dentistry. It is beautifully made. It is convenient to use it. And I ask parents to come in 1 week and 1 month. And week examination, I check if the baby have a real vision or not. And after 1 month, I ask the parents about the improvement or their satisfaction. I made all the sheets and asked the mothers to check what improved and what did not. And I rated the mother's satisfaction by 5-point scale from 1 to 5. 1 very unsatisfied, 3 equivocal, and 5 very satisfied. And I made a database for analysis like this. And here you see a name and small diagnosis and type of tongue tie, type of lip tie, and the assessment items, total score, presenting symptoms, post-operative improvement, post-operative satisfaction, and the sense of presence of adhesion. Now I like to report the result of the study. Excuse me, my mouth is dry. That's okay, that's Mark's copy. I had an operation of 525 patients with tongue tie and or lip tie at the Musashino Tokishugai Hospital for the past 4 years, 2015 to 2019. And this is another local hospital, and cherry blossom is beautiful in the springtime. And the number of release ties are 467 tongue ties and 367 lip ties. And that means a total number of patients of 525, so that there are overlap of cases here. 59, thank you very much. Yeah, very kind. 59% patients had the both tongue tie release and lip tie release. Not too special. So, the visit group of patients, mostly they came from lactation consultants and midwives, and there are only a few from a referral from pediatricians, with 12%. But it used to be 4 or 5% 2-3 years ago, so it's increasing. Number is increasing. But many patients come by internet or mouth, word of mouth. Gender, the male is preponderant as previous study. The 60%. Male to female ratio is 1.7. And age distribution is shown here. 49% of patients who are under 4 months old. And the old age groups here, over 3 years old, are mostly patients with speech problems. And heredity has been seen in 48%, almost half of the patients. And they inherited, of course, from parents, but they share the trait with the siblings in almost 1/3. And they are presenting symptoms. One patient had 2 or 3 symptoms, so the number is greater than 525. Correlates, 59%, nipple pain, 28%, breast problems, 22%, tongue deformities, 24%, speech problems, 9%, dental problems, 6%. Now, the mean age of correlates and nipple pain was 2.5 months, and their speech problem was 4.9, almost 5 years old. And the frequencies of 4 types of tongue-tie, about half of patients had anterior type, and the tongue tip type was the least number. The score distribution, the mean score was 4.6, and the peak was at the score of 4, that occupied 29%, and the other scores distributed almost symmetrical on both sides. The correlation between mean score and tongue type. Tongue tip type, mean score was 2.5, and that of anterior type was 3.9, and that of tenting type 4.9, and of posterior type was 7.1. It correlated well. I think the classification is almost right. It is parallel with the severity of the tongue-tie abnormalization. Mean score of prolapse and nipple pain was 4.4 and 4.6 respectively. It's almost the same, but the speech problems was lower, 3.3, 3.6 after 1 month. They needed rehabilitation after this, 1 year, 2 years sometimes. Now, if I analyze the each items from 1 to 5, the attachment to oral floor is the lowest score in prolapse, nipple pain, and speech problems. I think this reflects mostly the severity of those symptoms. And the adhesion was seen in 52%, even though with the stretching. That is one problem. The improvement of symptoms at 1 month after surgery, 87% of prolapse and 77% of nipple pain improved, and 58%, only 58% improved in speech at the point of 1 month. And I saw a correlation between improvement of prolapse, nipple pain, and procedures. Prolapse is indicated in blue, and the nipple pain is shown in the brown color. And here, this group is tongue-tie release alone group, and this is both tongue-tie and lip-tie released. And in this group, lip-tie alone is released because there is no indication of tongue-tie. And here I see the improvement of prolapse and nipple pains get better when the tongue-tie release is, lip-tie release is added to the tongue-tie. And satisfaction at 1 month after surgery. 97% of patients are satisfied or very satisfied. So I think it's a good result. And satisfaction of prolapse and nipple pain are 4.6, but the satisfaction of speech is higher, which is interesting, isn't it? Because the improvement of speech was not good as the improvement of prolapse and nipple pain after 1 month, but they are more satisfied. Why is that? I think there is something stressful for mothers in the untitled. I think it's a stretching. Stretching is stressful. It's a pain in the tongue for mothers. Now, a correlation between satisfaction with poor large nipple pain and procedures. Here also, the satisfaction are almost same in tongue tie and both tiles almost the same, but the satisfaction of lip tie alone is better because the stretching of lip tie is much easier and it's not stressful to mothers. So conclusions. 1. Simplified tongue tie score was useful in decision making for surgery. 2. Among 5 evaluation items, attachment to oral floor was the lowest score. 3. 97% of mothers were satisfied with the result. 4. Poor large and nipple pain improved better when lip tie release was added. 5. Re-adhesion was observed in about half of patients at 1 week after operation. Stretching exercises following the tie release is necessary, but stretching seems to have made mothers' satisfaction lower. Last slide. I'm sending these messages to the Japanese medical societies with patients. But I believe the Oriental saying, constant dripping wears away the stone. Constant dripping wears away the stone. That's our philosophy. Thank you very much.